You know, in medicine, we're so often focused on the physical stuff. But what happens when a patient's suffering runs deeper, when they have this profound sense of just not being able to cope anymore? This isn't just garden variety sadness. It's a specific psychological state called demoralization. Today, we're going to dive deep into a major systematic review from the journal Clinical Psychology Review to really understand what demoralization is, why it gets missed so often, and why it's absolutely critical for patient care.
So what exactly are we talking about here? Well, the term was first floated by pioneers like Jerome Frank. He used it to describe this feeling of subjective incompetence, basically a loss of your own sense of agency, or feeling like you failed to meet expectations. At its heart, it's this persistent, nagging feeling that you are simply unable to manage a major problem in your life.
But let's be real. In the fast-paced world of a clinic, with a million things to focus on, how much does this really matter for patients who are dealing with everything from a chronic illness to end-of-life care? Well, as this review makes incredibly clear, the answer is, it matters a whole lot.
Okay, so let's get into it. Here's the game plan for this explainer. We'll kick things off with how clinicians actually measure demoralization. Then, we'll get into the core findings, how common it is, and how it stacks up against other conditions. And finally, we'll wrap up with the crucial clinical implications and the big take-home message from this really comprehensive paper.
So before we can even get into how widespread this is, we've got to ask, how do you even measure it? The systematic review found that researchers pretty much rely on two key instruments to figure out what's going on.
These are the two big ones. On one side, you have the DCPR. Think of this as a structured interview that gives a clear categorical diagnosis. It's kind of like a yes-no question. Is demoralization present or is it absent? It's especially useful for understanding how people deal with chronic stress. Then on the other side, you've got the demoralization scale, or DS. This is more of a questionnaire that measures the severity and frequency of symptoms, putting it on a scale. It's often used to capture that deep existential distress you see in patients near the end of their lives.
All right, so now we know how they measure it. Let's get to the really juicy part of this review. Just how common is this condition? And honestly, the findings are pretty eye-opening. This chart tells a really powerful story. Using those DCPR criteria, the prevalence of demoralization starts at about 7.6% in the general population, okay? But watch what happens when we step into a clinical setting. It doubles to 15% in primary care patients. And then it just explodes to 38% for people who are frequently seeing doctors. I mean, the link between medical illness and the psychological state is crystal clear.
And this right here is so important because it shows that demoralization isn't just something that happens with terminal illness. Not at all. The review found super high rates across a whole range of chronic conditions. I mean, look at this. Almost 37% of patients with hypertension, 32% with IBS, 29% with breast cancer. They all met the diagnostic criteria. This is a massive source of suffering in everyday medical practice.
That being said, when we do look specifically at palliative and end-of-life care, this time, using the demoralization scale, the numbers get, well, incredibly stark. The review found studies are up to 64% of cancer patients at the end of life were experiencing moderate to high levels of demoralization. That really highlights just how profound this kind of existential distress can be.
Okay, let's pivot to what might be one of the most critical takeaways from this entire paper: the relationship between demoralization and major depression. Now, they can feel similar, but as we're about to see, clinically, they are not the same thing.
And the review could not be clearer on this. While demoralization and depression can definitely coexist, and they often do, they are separate and independent clinical issues. And confusing the two, that can have huge consequences for how a patient is treated.
This quote from a study on cancer patients just nails the point. About half of the patients who were diagnosed with demoralization did not meet the criteria for major depressive disorder. Think about that. A patient can be deeply, deeply demoralized, feeling helpless and incompetent without being clinically depressed.
So it really boils down to this difference in the core feeling, right? For demoralization, it's that sense of subjective incompetence. The feeling of, I just can't cope. For major depression, a key feature is often anhedonia, that loss of pleasure or interest in anything. And get this, one study found demoralization was actually twice as common as major depression among medical outpatients. That means we might be overlooking a huge piece of the clinical puzzle.
And this is where that distinction becomes not just important, but critically important. We have to talk about the powerful and frankly dangerous link that this review found between demoralization and the risk of suicide.
Yeah, this number it's really sobering.
One study found that demoralization can crank up the effect on suicidal thoughts by over 75%, even after you account for the impact of depression. What that tells us is that demoralization isn't just riding on depression's coattails when it comes to suicide risk. No way. It is a potent independent risk factor all on its own, and that makes identifying it a clinical emergency.
So, after all that data, what does this actually mean in the real world? What are the practical takeaways here for doctors, therapists, and patients?
Well, the implications here are massive. First off, this isn't some niche problem. It's a common state of distress found everywhere in medicine, and it's consistently linked to a worse quality of life and poorer health outcomes. And crucially, if a clinician only screens for depression, they might completely miss the patient's core struggle. By identifying demoralization specifically, we open the door to treatments that can actually get at that root problem of feeling unable to cope.
So, based on all this evidence, the review lays out a really clear path forward for clinicians. First, you've got to actively screen for and diagnose demoralization using validated tools like the DCPR. Second, you have to be rigorous about separating it out from depression. And third, and this is the whole point, this allows you to develop and use treatments that are tailored specifically to demoralization. Therapies that help rebuild a patient's sense of coping, purpose, and personal agency, which might look very different from standard antidepressant treatments.
Okay, so after sifting through a whopping 188 different papers on this, what's the big takeaway? What's the final word from this systematic review?
It all comes down to this. Demoralization is a real, it's a measurable, and it's a clinically significant condition. It is not just a symptom of depression. It's its own thing, centered on that feeling of incompetence and helplessness. And recognizing that difference is absolutely vital if we want to provide accurate diagnoses and ultimately more effective care for our patients.
And that really leaves us with a big question to chew on. If we truly started integrating the concept of demoralization into our standard practice, in oncology, in cardiology, in primary care, you name it, how might that fundamentally change our entire approach to mental and emotional health within the medical system? Something to think about.